But it just seems outrageous that these three things are done. So the IMM 101, the injection would be given how often?
Oh, sorry. When we gave it, we would give it once, and then a month later.
Oh, right.
And then 3 months later,
right.
And then 6 months, and then annual, say a 5-year program. Because once it's boosted, once it gets to a certain level, it stays up for much longer.
So you're talking about a visit to a practice nurse 4 times in the first year. It's nothing, is it?
It would be nothing. And of course, I've done it on myself.
I wish I had it. Yeah, I'd love to have it.
When we were doing the trials and the COVID lockdown came along, I had to gather up everybody. They stopped all the trials. It was absolutely madness. But we had stuff that was meant to be for crushing. So I knew that it boosted the T-cell response. I gave it to myself and measured. It was fascinating that if I'd had cancer or very immunosuppressed, I would then needed to have given it a month and then another 3 months. It lasted over 2 years with me.
Did you have any colds or COVID in that time?
Nothing. Absolutely nothing. Well, I had COVID. I mounted an incredible response to COVID because we were able to test the T-cell. I told everybody at the time, forget antibodies, forget vaccines in making antibodies. It's the T-cell response that guards against these things.
Cellular immunity. Absolutely.
Cellular immunity. So anyway, we were doing a lot of T-cell responses for cancer, everything. And one of the guys got interested in doing COVID, and he wanted me, because I was unvaccinated, for my response. And he came back and he told me, he said, "You've got the highest T-cell response against the SARS virus we've ever seen. Have you had it?" And I said, "No, I've never been ill with it, and I've never had the vaccine." And it was twice as high as all these people in their 30s who had had 2 shots of ordinary vaccine. So that is why, I'm a living example that you need high T-cell responses. And I've never had, at that time, going through the cold or flu either at all, until recently. I had a bad few weeks of it. I think it was probably RSV virus going around.
Okay. Oh, really?
So many people I know had it. It wasn't, you didn't have to stay in bed or anything. It was just very irritating symptoms.
Right.
But but overall, you're talking about percentages of catching things, and when you do, how ill you are with it. And there's no doubt that all the people who were on this for the early melanoma trials, they picked up, they never get colds or flu. And that was the big signal to me that it was the T-cell innate thing that was controlling the cancer, not any antibody or anything like that.
And preventing the infection. So obviously you'd had COVID without realising you had it, and because you were protected by the IMM 101, basically you didn't even know you had it, but you still mounted this fantastic cellular immune response. And you probably still got.
I almost certainly do have it. It's a T-cell that be there long term. It would have activated the memory T-cell, so they're programs. So if I get exposed to it again, up there.
Well, of course, it'd be a different variant now, so you could be reinfected with a different variant, but.
But the T-cells go for the more conserved areas that the antibody. This idea of
isn't that clever? The T-cells actually go for the more conserved areas of the virus. That is amazing.
And that was the basis of how Børge Sørensen, who I did the HIV vaccine with in Norway, that was the way he picked what should be in the vaccine, not the whole envelope that the Americans did time after time after time, but he just picked the epitopes that the T-cells would go for, and which, if they changed, the virus wouldn't survive. A really sensible, logical way. And again, this has been turned down by all the big authorities again and again and again. It just seems rather like, to me, that the big pharma's running this. It doesn't want anyone to be killed.
Absolutely.
Chronic users of its products.
Absolutely, yeah. But I'm just, my mind's blown by that. So we've got the T cells that we all have. And when a virus comes along, it says, oh, well, that bit on the edge of the virus there, that'll probably mutate next week. I'll ignore that bit. But this bit in the core of the virus, that's going to stay the same. So what I'll do is I'll make an immune response against the core part, because there's no point doing that, but that's going to change next week. It's really clever that it can do that.
Yeah.
And really brilliant pharmacologists can duplicate that, saying, okay, ignore the bits that are going to change. Yeah. Let's go for the core antigens that are going to stay the same regardless of how much the virus mutates, because it's still in this case it's still a SARS coronavirus too. It doesn't become doesn't become a smallpox virus or something. It's still it's still basically the same, and we can duplicate that. But that's so amazing that the body can do that in the first place. Amazing that we can duplicate that, and not surprising at all that Big Pharma turns that down. It's,
well, I mean, the obvious conclusion I immediately jumped to is that there's no need for flu vaccines if you gave this, and you wouldn't have to mess around every year trying to inaccurately predict the next variant.
Let's drift off into a parallel universe. Let's just imagine that instead of the vaccine of the COVID vaccine rollout, we rolled out the IMM 101. Vacci, Mycobacterium vacci vaccine, and we gave that to everyone. Then it's quite possible, without venturing into the realms of complete fantasy, that would have prevented the majority of viral infections, including COVID and influenza, over the next year or two. And it's also quite conceivable that would have massively reduced the amount of new cancer diagnoses over the next decade or two. I mean, am I getting carried away?
Yeah. Well, I'm actually, you're hitting a raw nerve here, because I actually said at the outbreak of the COVID, when they were, but this is like pre-lockdown, we had a lot of people in the hospital getting ill. I actually offered this to Whitty. I'd established that there was enough stored in the batch that we could have offered it to everybody in the front line in the NHS, and say in the south of London, and we wouldn't have had enough for the north of London, but you could have used that as a control. And guess what? And all the papers, everything available. Do you know what his response was?
Our chief medical officer, who's supposedly a highly educated physician, I imagine he welcomed it with open arms, did he, Gus?
Yes, well, unfortunately, people are overeducated above their intelligence these days. So he said it needs more work in animals. I said it's been in thousands of people in the big TB trials. It's been in hundreds of people for this, and it works the T cell. And they're just fixated on this vaccine program. And I mean, the fact everybody rolled out did the same. It was like a mass psyop that was going on.
Yeah.
And this is why, I'll mention it again. I ended up editing the book "Death of Science" because that's exactly what was going on. People were not looking at the evidence, and it was worse than that. They suppressed all debate.
Yeah.
So people who wanted to
we'll put the link. It's excellent.
Parts of it.
Nearly all. Yeah, nearly all.
and so this to me is the most Orwellian, draconian thing that happened, that even my own colleagues wouldn't debate.
I never thought in our lifetimes that we'd have to start. I thought we could spend our lives working out how to look after patients. I never thought we'd have to fight these political battles. And personally, I'm personally offended by it, because I have to spend time thinking about pussyfooting around what I can say and what I can't say, when I should be spending my entire time working out how to prevent human pain, suffering and death. And the role of the politicians and the administrators should be saying, well, Professor Dalgleish, how can we help you do this?
Well, I agree entirely. That's exactly what they should do. Yeah. And I mean, the fact they cannot be totally unaware, because of so many patients have benefited from these immunological programs. I mean, I was doing 25 years ago, and now it's become de rigueur, and it's the same thing with things like low-dose naltrexone. I'm sure that in 10 years' time, it will become de rigueur eventually, because there will be a force. But I want it now. because there's no need. There's no need for any other work.
We have relatives dying of cancer with cancer now. We have friends with chronic inflammatory conditions now. I just couldn't agree more.
And the other thing is, which is annoying, that I know Whitty and people like that have dismissed me as a cancer doc, and I don't know anything about infection and immunity and what have you, which is a bit rich, knowing that my impact on HIV is greater than probably anybody else at the moment.
The CD4 receptor, I think you're a record
and the pathogenesis. We worked out the pathogenesis of it.
I think your HIV record is more impressive than people, I don't know, maybe people like Tony Fauci,
Well, the thing about my record in HIV and Tony Fauci's is that I wrote and did it all myself, where Tony puts his name on anybody else's work he thinks is good. He cannot possibly have written all those papers. You know how it works. And that's the culture. They put the name on if it's going to be good. Anyhow, we're not going to go there. But the other thing that I think is really important that people dismiss is the thalidomide story.
Yes.
I saw clinically patients who were steroid-resistant, horrible disease. Yeah. And I spoke to a chap called Mike Denman, who was in Northwick Park when I was there at the time. Yep. And I said, with these things, would it not be worth trying thalidomide on these people? And he agreed, and then he was able to tell me the story of a friend of his in Israel who had used thalidomide for somebody with bad leprosy to help him sleep, and it improved the leprosy. And this is what we call, it inhibits this Th2 inflammatory response. So I used it on a couple of, very rare, these patients, but they had fantastic responses. I mean, miracles.
Which patients?
They were patients with steroid-resistant autoimmunity,
right.
Really badly, involving multiple ulcerations from the mouth to the anus, with terrible skin diseases, what have you, and even high-dose steroids, and then they'd be losing weight because they couldn't eat or drink, and they had to be on drips and what have you. And when we gave the first thalidomide, they couldn't even swallow, so I had to squirt it down there. But they improved. The next day they were improving, and they were completely better 2 days later. And we saw that with several of these serious autoimmune diseases, some horrible skin and joint problems.
The thalidomide was available at the time, was it? You could get thalidomide from the pharmacy.
We could only get it on a special permission, which fortunately Mike Denman had that permission to do it, so he allowed me to do it. And it was then that I realised that it was going to be exceptionally good for HIV patients with anorexia. And then the next leap was cachexia cancer patients. So that's what we wanted to use it for. But, once again, the establishment is full of people who cannot see beyond their own feet. And they all said, no, this drug causes birth defects. We can't possibly allow you to do this. And I said, but all the patients when we want to give it to are not going to be women of pregnant age. And in cancer, if they are, we give chemotherapy. And it's far more tetragenic than thalidomide. We just make sure they're not pregnant. It's not. At any rate, they turned that down. I wrote a terrible review article of how it could be so beneficial in all these things. And this is the one case of good big pharma, because they weren't. They were a very small company, and that was Celgene, and they actually funded my lab and a clinical trial which was positive, and we took on from there, and I realised that this drug could be improved. It took a long fight, but we got variants made, lenalidomide, pomalidomide. They are the drugs for myeloma, multiple myeloma, widely used in lymphoma, etc. So, that track record is really, really important for low-dose naltrexone, because I see low-dose naltrexone as a very similar, more broadly applicable thing to the thalidomide analogues. Where
not only that, it's your personal track record. You've taken a drug like thalidomide, you've constructed a form called lenalidomide. you've started using it in myeloma and lymphoma, and now that's pretty well standard treatment across the world, is it?
I was told that it still sells about $10 billion worldwide. So, I mean,
are you in for a cut?
I've done very, very, very well out of that.
Yeah. So you discovered it and you get diddly squat.
Yeah, well, actually, yes, that's true, but I did get my lab funded by them at a very, very good rate.
I should hope so. Out of 10 billion, I think they can afford that.
No, this was long before they started making that money. They funded me well.
Oh, okay, right. Well, a good investment then.
Yeah, it was because the guy at the top, he just intuitively trusted me, whereas many of the people who sit on these committees said no, he's got no track record, etc. And he trusted me, and he got massively rewarded. I got rewarded because I was able to have my university labs funded outside, which is really important these days.
Yeah, your boss would be pleased with you.
And after the MRC and the CRUK and the Wellcome Trust had all turned me down for doing the same project, so I was delighted. So I'm not. I'm just really, really delighted, and I've got friends, very good friends of mine, who today are stable because of they're on lenalidomide every day.
Yeah, but isn't it incredible? You know, you there have developed. Basically, you've discovered a completely new application that's benefited millions of people really around the world, has made billions of dollars. Most people would have made sure that their invention benefited them, and you could have been like in the Bill Gates category. But you have lived this life which is just to ease human pain, suffering, and death. And the fact that someone else has made $10 billion out of it is just a bit of a side effect, really.
Well, it shows. I mean, they listened to me when nobody else would listen.
Yeah.
They reaped the rewards. They were a small biotech with only 12 employees when they came to this decision that they'd fund me to do work on thalidomide. So that was. So, but and at one stage they were bigger than GSK. Wow. You know how they do these things on the stock.
Yeah, just because they listen to you and the other experts, it's just incredible. Are 4.5 milligram tablets of naltrexone available? Because I looked in BNF this morning, I could only see 25 and 50s.
Right, this is a very interesting area. They're 25, 50s, etc., and you take about 200 milligrams if you're going to use them in opiates.
Yeah.
So these very small doses are not available without what they call compounding. So you have to take the 50 milligram, grind it up, weigh it out, repackage it. That's an expensive business to do. So
that's why we have pharmacists, isn't it? They should. Any pharmacist should be able to do that.
Well, they do, but it'll cost you because it's not on the NHS.
Right, okay.
So Dixon's pharmacist in Glasgow started to get this demand for multiple sclerosis patients. And indeed, there are really good papers showing benefits of multiple sclerosis. So once again, why is it not used? But the demand is in the thousands. Glasgow being the highest area of multiple sclerosis in the country. So there's big demand. They're also probably the area with the lowest vitamin D in the country as well.
That was just came to my mind. It's a built-up city. It's far north. It's people are indoors a lot of the time because it's cold.
Very bad lifestyle choices. So MS is a big issue. It clearly works. I've spoken to the GPs up there, neurologists. They love using the low-dose naltrexone, and they've actually managed with cases, but you have to prove the case that low-dose naltrexone has revolutionised their multiple sclerosis. Then they go for the NHS to approve it and pay for it for those patients. And it makes perfect sense because it's dirt cheap compared to the things that are approved, which are in the thousands, whereas this is in the...
But it's got to be 4.5 milligrams. In your paper it said if you give 6 milligrams, the effect reduces. I mean, do you work it out in terms of milligrams per kilogram, or is just 4.5 milligrams seems to be the magic dose?
smaller people feel better on 3 milligrams. So they now make the doses in 1.5, 3, and 4.5, and the chemists usually want me to start all the patients on just a 1 milligram first, which they do in a dropper form, just to make sure there's no unexpected interactions with other things.
I mean, if we had that as a liquid, it'd be really easy to do. So for example, I've given huge amounts of intravenous morphine, and it comes in 1 mil, 10 milligrams in a mil. And because that's a bit hard to titrate, what we do is we pull the 1 mil of morphine into your syringe, then you add your 10 mils of water or saline, and because you're adding that you get perfect distribution. Then when you've given 1 mil, you've given 0. You're given so it's 1 mil equals 1 milligram. So that would be really easy to do if we had it in a liquid preparation for naltrexone.